That's so funny. Uh, I just started recording the session. Anyway, your voices cannot be heard, but just your names on the screen will appear. And most what will be in those sessions is going to be my voice. The sad thing is, last session, I was using another computer. I recorded and everything, and then the whole thing went off, so I didn't have a recording for last session to upload in the YouTube. But hopefully it is in your memories. Yes, Najla, don't be so shocked. Okay, I'll start. You can still see the presentation I'm showing, right? Can you see? Yeah. Is it in presentation mode right now? Okay, excellent. So, good evening, everyone. We're starting with session 6. Today, the chapter focuses on the data analytics for the improvement of healthcare quality. They don't focus on the analysis technique, but mostly like how did data analysis start, how did it grow, and so on. We will be covering those topics, describing the current landscape of data analytics in healthcare, discuss the differences between the different stages in the maturities, and then discuss key strategic elements needed to advance analytics in healthcare, discuss how advanced analytics can be applied in clinical and population health setting, as well as measuring healthcare value, and then describe the differences between accuracy and precision of data. So the first thing they talked about is that with the introduction of technology into the healthcare, the requirement for data included the requirement for timely data that can be accessed when needed, as well as the transformation of data into meaningful information that can be then translated for the improvement in the care quality that we are offering to our patients. So what happened was there are barriers to both these aspects, and these barriers included fragmentation of the healthcare informations inside the electronic healthcare record, fragmented informations and patient data, and the need to go through several stages or areas to collect the data required, actually. Proprietary collection. Here is talking about the data ownership. The organizations are not comfortable to actually provide or share the data with others. Everybody collects the data and keeps them for themselves, and does not. And there are also like legal implications related to data privacy that stops the organizations from sharing the data with others, as well, which is leads us to the next point, which is the limited data sharing. So all of these are barriers to the having an appropriate including of technology or data from the technology. Like the expectation was when we have the electronic healthcare records, we will definitely have seamless access to data in a timely manner, but that was not the case. In the implementation of electronic healthcare record, the expectation or the expected business case that was put at the time was there's going to be $80 billion savings from implementing electronic healthcare records. The expectation was it's going to enhance the quality of care, the quality of communication, the transition of patient care elements, the availability of data on a timely manner. So when they calculated the costs and the complications that relates to all of those elements, they approximated the savings to be $80 billion. But unfortunately, the cost of healthcare kept increasing, and this cost saving was never achieved. So the discussion here on the failures were due to those elements. A sluggish adoption of the health information technology systems. We talked about this yesterday. Last Saturday when we were talking about health informatics. Can you tell me how was this solved when the initial uptake of the health information systems was very low initially, what's the trick that was used to increase the organization's using of healthcare health informatics? Anyone remembers? It's a very silent group. I can't hear anything. It says here that the failure to achieve this 80 billion saving and the increase in the cost of the electronic healthcare records over time was due to one of the reasons was the sluggish adoption of the health information technology systems. So in our previous chapter, we talked about how this issue was overcome, or and the adoption of the electronic healthcare record was encouraged. Do you remember how was that? How was that done? Excellent. So it was a requirement by Medicaid and Medicare. It's not only part of the health insurance. It was that they could be part of a certain reimbursement scheme or benefit scheme only if they have, through Medicaid and Medicare, only if they have an electronic healthcare system. And that's how the adoption rate increased since then. The other reason for failure to achieve the expected saving was the poor interoperability of systems. Anybody can guess what does this mean? Like what? Give me an example. Sorry, if someone can admit those people who are joining, please. What does it mean that there was a poor operate? Okay, I'm not gonna read it anymore. You can see it in front of you. Anyone remembers? It simply means, yep. So it basically means that the systems do not talk to each other. So if you are using one system in the pre-hospital admission phase, whether it's a clinic or an emergency or another private entity, that system does not talk to the system you might have in the hospital, does not talk to the system that might you have in the post-discharge care services and the clinics and so on. So because the aim was to improve communication and remove all of those challenges that relate to not having an electronic healthcare record, but because they were interoperable, it resulted in this situation. And then it says limited ease of use. So when we talk about ease of use, it's ease of use of everyone, the users, the data extractors, the administrators, the all the details. And last time we talked about usability of the health informatics systems. We talked about something called um, uh, the TURF framework, actually. And that TURF framework translated things, the usability of the system into usable, useful, and satisfying. Which one did we say is the most, the aim for any health informatics system? Satisfying. Remember, satisfying, we said, is the top. It's useful, it's easy to use, it does the job, and the clinicians or the people using it are satisfied with it. Okay, if you remember last time we gave the example that an electronic like Salamtech is useful. It's doing the job it's supposed to do, but what's the percentage of people that are satisfied with it? That's depends on the feedback that not every that doesn't have a very high um, percentage of satisfaction with using it. So can anybody remember what was the difference between useful and usable? Okay, you entertain. Okay, system. Yeah. So the first answer was exchanging two. The useful is that the system is doing what it has to do. It's functional. Usable means it is doing the function, but it's also easy to use, easy to learn, and there are a lot of elements like that. It has details on times, tasks, error preventions and recovery, and so on. So, okay, going back to here, and then another reason for the failure of the implementation of the electronic healthcare records was the failure to re-engineer care processes. Here is talking mainly about re-engineering care processes to actually fit with the way we currently use electronic healthcare records, and all of those elements was the reason why the implementation of electronic healthcare record initially was failed. Okay, then here they define again the health informatics, which is similar to the definition we took last time. It says health informatics is the interdisciplinary study of the design, development, adoption, and application of IT-based innovations in healthcare services, delivery, management, and planning. So it's even more wider than just the health informatics. Health informatics is one of the elements, the electronic healthcare record is one of the elements under health informatics, but health informatics is way wider than that. Here, when it's talking about advancing data analytics maturity, there is a certain level of increase in the sophistications of data models, or in the maturity of data models, and we will be seeing this in the next slide. Or maybe I'll just go there and come back. Okay. So they say that, like, historically, when it started, the most basic form of data maturity is data reporting. Okay. So you get a clinical report from the medical record, you get financial reports, you get lab tests, you get any documents or any report that you need, and that's the data reporting. Very basic, very straightforward. And the example they gave here, and it's like labs that might suggest who had sepsis or the number of patients who were diagnosed with sepsis. Very straightforward. The next level of maturity is having data analytics. When we say data analytics, here they talk about shortening event to reporting time. So it's easy to find the data in the most timely manner, and then transforming data and translating this to meaningful clinical relevance. Okay, so here they give examples to identifying characteristics of patients with sepsis and patterns in sepsis care. Can anybody give me about data analytics that we use as part of the patient care? Say it again. The Noor platform is data analytics and reporting, yes. And here, but do you have an example of something that can be used for meaningful clinical relevance? Like here, they talked about sepsis characteristics for patients. What else do we use for data analytics that's even available to the frontliners to use on a timely basis? The screening tools, definitely. The early warning score is one of those elements as well. You do the vitals, and then it tells you that the patient is at certain risk. When you do, as you say, the screenings, it tells you that the patient might be at risk of something. And this links to the next one, which is the predictive analysis. It's linking the likelihood of outcomes to care decisions for populations, or predicting financial outcome, or linking strategies across former silos in the infrastructure. So here they're talking about predicting which patients are at risk of a certain disease or a certain condition. So certain assessments you do would tell you that this patient might be at risk of, a septic shock based on their vital signs and their criteria and so on. So it predicts certain patterns in the conditions of the patient. the last or the highest level of data maturity, which happens over time, is the prescriptive analytics. Prescriptive analytics is also called decision support data. And here it says they integrating the best evidence into delivery systems, infrastructures. EMR-based recommendation and alerts is part of the prescriptive analytics. Integrated plans for care across continuum, and then utilizing big data bidirectionally. So to improve the care as well as to improve the data reporting. So here they're giving the example of building tools in the EMR to trigger evidence-based care. Okay. I'm trying to look for another example for predictive analysis. And I think I might have just lost the allergy could be. So when we talked, remember last time we also talked about decision support systems. So we talked about allergy, we talked about alerts that come up to you to medications, that are prescribed and might not be in line with the patient diagnosis. So these are all the prescriptive analysis where the system uses data in the background and then comes up with a warning or an alert for the person using the system. As we go. Mhm. Excellent. Definitely, definitely. And this is very much prescriptive analytics because it's using data on the genetic study that were done on to patients, and depending on historical data that were done on studies and evidence-based practices to suggest that maybe then this treatment might not be the best possible or best available treatment based on the genomics and the genetic testings of the patients. That's an excellent way of thinking of the prescriptive analysis. Okay. So then they talk about the output can be delivered to the bedside, like the people who are using the care at the bedside through visualization tools. And the idea is that the idea of the data analytics is to benefit not only the administrators who are collecting the data or the management. When we're talking here, it's that we're looking for the people at the pre-hospital, the physician offices, which are our clinics, hospitals, and hospital web networks would benefit from those data and review it on a regular basis. But they say there is a cultural resistance always to the data and the use of the data as a sort of truth, especially when you are talking about the very early levels of maturity. And I'm sorry, I forgot there was one point that I did not cover here. Or 2 points. Here it says to achieve the value from advancing analytics, you need to have the right expertise such as informatics team and data analysts. You need to create strategies to manage significant organizational change. So people will start, when they see data, they will start asking for better technology, or they will start, the need or the desire for having more and more data will increase, and you need to have strategies to manage those changes. And then you need to have an effective approach of data governance, and we will talk about data governance in more details in the upcoming slides. And here then they say that the evolution of informatics from data reporting to sophisticated analytics require collaborative teams to drive improvement strategies. So here they're saying it's not just the job of one department or one person or even a system to create those this evolution that we talked about. So it needs a team, which is they are not forgetting the human factor interactions and their value in the healthcare system delivery. Can you think of examples of team members that could help with the data analytics and reporting. Excellent. So informatics, frontliners, so else? Analysts, data analysts, true. So we did the data people and we did the frontliners. What's the in between? You definitely need your leadership to buy in and to help in the data collection. What else? Who else? Auditors or data collectors? Yes, definitely. Excellent. So the IT system designers, and we'll be talking later about some of the challenges with collecting data is that even the initial design was insufficient, that it doesn't help you to actually capture the data that you're looking for. Uh, okay. Sorry. Fine. So going forward to the next point, we say that there are certain challenges when when you start collecting data at the early stages, and there are stages for data acceptance. These include stage one. People will tell you the data are wrong. Have we seen this? Does this remind us of anyone? Have you ever heard someone telling you that the data is wrong? Especially when something is not being measured and you start measuring it for the first time and it doesn't look as good and as shiny as people want it to look, the first interaction or the first reaction from the people is going to be, oh no, the data is wrong. We've had groups of people in the hospital collecting data manually because they did not trust the data that the electronic healthcare record was giving them. And they continued doing this for years and years while there was a fully automated system that could give them the same data easily on real-time basis without the need of a person to sit and actually collect the data. So this is the first, belief. And I can say, like, currently in our hospital, there is this the data governance activity starting, where if people say the data is wrong, we go back and we say, okay, fine, it's wrong. Let's look at it and let's understand why it is wrong, and is it something that the system needs to fix, or is it something, that the definition is not matching, or what's happening? And after further study, we started finding more and more people thinking, well, the data is right, but it's not my problem. Someone else has to do something about it. The administration has to do something about it. The quality team has to do something about it. The improvement teams have to do something about it. It's the nurses, it's the physicians, it's the pharmacists. It is, without actually making an effort. So here they are, just removing responsibility for the data. Stage three, well, yes, the data is right. It is, sorry. For the first part, they will say the data is right, but it's not a problem. Yeah. So this is within our acceptance level. This is okay. This is what we have. It's fine. That's it. Yeah. With this definition, this is the only data we can get, and we are fine with that. We are meeting some standard or the other already. So we don't need really, to worry about this data. The next step is going to be, yes, the data is right, but it's not my problem. Somebody else has to make sure they fix the problem. The last one is the data are right. It is my problem. It is our problem. And, the person or the organization starts taking activity actually in order in order to what you call it, to solve or resolve the problem or implement the quality improvement strategy. So there are some studies that started even linking this to the 5 stages of denial. You know, when you're grieving, you start with denial, I don't know, bargaining, anger, something, then acceptance is going to be the last stage. And the only difference here is they added a point under bargaining that says, oh, let's bargain the limits, let's increase the tolerance levels, let's do this. And then the rest of the stages are already there. Any questions on this slide before I move forward? Okay. Okay. And then they say that the changes in the culture of the data analytics are going to happen, and as the organization matures towards those levels of healthcare that we talked about, the healthcare data analytics maturity levels, there are certain criteria to evaluate these changes. And then they say there's even within a same organization, you could have multiple levels of maturity between the different departments and the different services. And I'm sure we could see this where some departments don't even use any data. Some departments are very data driven in every practice or in every decision that they take. So there are models or criteria to evaluate change in health system analytics culture and how we are developing. And they always look at those elements when evaluating that. They look at the data sources. So as an organization, what's the scope and the number of data sources that feeds into the organization analytics? The more you have, or depending on on these and the quality of these data sources, you'll be able to judge and decide how you are growing. The data quality, they will look at the consistency and the accuracy and the integrity of the data being reported. Data currency as in the timeliness. Is it really timely at the time when you most need it, or is it only provided 3 months after the actual event or the actual time the data was required? So it's the timeliness of the data as well as the frequency that it's being used. And then we have the analytic features. So this is now as an organization, what's the sophistication of data that we have, from reporting to predictive modeling and workflow integrations, in order to achieve all of those levels. And then it looks at user profiles. So who are the people who are using the data? Is it analysts? Is it skilled daily users? Is it the management? Who's really using the data? And the more the data goes into more maturity, you expect there's going to be more users of the data growing with you. And then it looks at the adoption profiles. So the organizational sophistications, from report users to performance management cultures. How do we use the data? How do we adopt it? How do we integrate it within our practices on a regular basis? So when you study these elements, it helps you identify and think, is my organization currently in the reporting phase, in the analytic phase, predictive and prescriptive? Okay. Then here we're talking still within the advancing data analytics maturity. We've talked about the concept of data governance. And it says that data governance is the foundation of any healthcare system that strives to use data to improve care. If you want to understand what's data governance in details, it includes those elements. So it has an interaction between the technology, the people, the processes. And then you would need to always clarify the ownership, the data ownership, the accessibility of the data, the security of the data, the quality of the data, as we said, and then transforming or translating the data you are collecting into knowledge that can be used for decision making, for improving practices, and whatever it is. So this is the concept of data governance overall. And here they say even data governance matures with the organization. It has a foundational level, and its foundational level data governance ensure that the data is of highest quality and easily accessible. In advanced applications, it then interacts with the strategy, making sure that there is a strategy behind increasing data content for use. If you look at the number of the data that's being collected currently, there is a lot of data, and sometimes it's not even used for any purpose, but people keep collecting it, they keep saving it, and they keep spending time and effort to collect the data, or requesting the IT and the data analysts to actually come up with a lot of more data. So the requirement is that once you have a very advanced data governance process, then they will have clear strategy on deciding what content to create, what content to use, how to govern, the data strategy. There are some organizations that even has data governance committees that's led by the CEO or the lead of transformation, or someone that really looks at, do we need those data? Do we need to come up with it? And do we need to request to approve the requests or not? And then it says the data governance allows organizations to implement best practices. They have a pool of analytics, so they could always come up with the data that's required. They standardize metrics, and this is one of the most important activities, that you have a standardized metrics. Now, we have several reports that going out on the same metric, and if you look at each one of those reports, everyone is reporting something different. So sometimes you would see the ED waiting time is measuring all patients, even those who left without being seen. Sometimes it's excluding those who left without being seen. Sometimes it's broken down into more details with additional inclusion and exclusion criteria. So the idea is to always have clear definition of the metrics to be standardized. And then here it also provides clinical decision support, because the data you're coming up would ideally help you to make decisions and make improvements in the care of the patients. And these could be used not only for quality improvement, they could also be used for clinical research, for specific patients or populations, care improvement, and so on. And then it also optimizes the electronic health record and the data warehousing. Data warehousing is just a term for how do we store and how do we save and how do we keep the data in a way that it can be used later on, and to extract additional information, or to even break it down to more required information. Following that, data governance must be iterative. So the word iterative, so let me read the whole statement. Data governance must be iterative to accommodate new evidence discovery, growing amount of data, evolving personal technologies, and shifting payment landscape. Can anyone tell me what does it mean to be iterative? What does it mean? Data governance must be iterative. Anyone would like to give it a go? Yeah. And don't use your Google to translate the word. Did I lose everyone already? Hello? It's very quiet. Okay, flexible is not the word. Anyone? That's not exactly the word. No. So iterative here means it should be done on a small cycle. So you don't set your data governance and your data analytics mechanisms considering that this is going to be staying the same for the next 5 years. It's going to be iterative, repetitive, frequently happening cycle of things. And the idea is that you're always reviewing and revising practices, data, and so on, to make sure that you are always adding new evidence discovery. So your metrics can change. For example, if you have a new evidence, you could start looking at a different metrics than the one you were using for. You might have additional amounts of data that requires additional breakdown or more advanced data warehousing. There could be personal technologies, like now with the wearable technologies that people are using it. How would we use that in order to analyze the data and use it for improvement and for population health, as well as the shifting of payment landscape. So the idea is that it's frequently happening. There is continuous review. It's not a stagnant, structure that happens at a frequent time frames. It is something that is accommodating the changes, and it's happening on a frequent levels. We talked about data ownership. They say then that the ownership and the privacy of healthcare data is a challenge. We talked about how organizations usually do not feel comfortable sharing their data with others. And then there are a lot of, healthcare information privacy laws and regulations. They are different between countries. In the same country, they're different from organization to organization, from regulator to regulator. So it is a challenge to people who are, using the data analytics and trying to mature. When we talk about data, the predictive analysis, which is the prescriptive analysis, which is the highest form of data analytics, it does not only require the hospital level data. Such decisions or improvements or level of maturity can happen only if the hospital is working as part of a network or as part of a governmental, at the government level or at the country level or even at the international level to come up with those prescriptive data. So it says here that most organizations are comfortable with the use of their own data for quality improvement. The use of data across multiple entities can create legal challenges, as we said, because of the differences on the legalities and laws across those departments. And that it requires collaboration with legal counsels to ensure protecting data privacy while allowing a robust usage within the healthcare systems. So this is a continuous discussion that's happening at all times to ensure we're not breaching patient confidentiality and we're not, putting our data privacy at risk. Here they moved on to the next point, which is data analytics to support population health. What do we mean by population health? Let me go back. We talked about this last time. I'm going to start looking and calling for names. Hold on. Maintaining the well-being of the population, the preventive medicine. So, sorry. Let's see. Population health reflects the health of patients across the continuum of care with the goal of improving health outcomes. So remember when we said we're not talking about the patient journey as one person, we're looking at the whole population. So we might take the pediatric population, we might take the geriatric as a population, and the aim of population health is to improve their care and their services. It also says it's an art and science of preventing disease. So this is the aim of the population health. It's preventing disease, prolonging life, promoting health through recognized efforts and in the society, organizations, public and private community and individuals. So it is way beyond what the hospital does. It's a program that involves all of the services within the organization. And it requires partnership and disciplines outside of the traditional care delivery, as we say. Sometimes the population health will focus on a certain geography. So they would tell you they are looking for the care of patients who live in the rural area in a certain country, for example. So this is a geographic consideration. They could also be looking at, for example, a condition. So here, for example, when they say they're looking for a condition of the asthmatic patients, pediatric or child asthma, the cardiovascular diseases, and so on. It might also focus on a payer, so a certain insurance group, or any characteristics that links the accountability for outcomes to that group of patients. So it doesn't only stop with these. You could group any group of populations or patients under this, and then study their healthcare and how it's impacted by a certain management. Okay. Okay. Population management. So this was population health initially. Population management, then, it's a concept in which common conditions or others linking elements may drive practitioner to create and implement prevention or care strategies and promote health of groups of patients. We've already mentioned, like, for example, children with asthma. Can you think of other population management strategies that we might be involved in here? Diabetes management, definitely, because it's very prevalent here. Obesity, definitely. Hypertension. But there were certain diseases that are even COVID, definitely. That was not population, that was what you call it. The whole world was affected by that. Yep. But it also, like, if we talk about even some of the KPIs we used to have consistently over the past couple of years. Sorry, we had the stroke, the MI. So there certain prevalence and certain diseases and certain ideas and the management. Yes, we have certain measures to manage them within their acute care phase, but it even goes beyond that, where it also deals with the management of the patient at home, the exercise regime, the weight loss, the diet scheme that the patients are going to go on, and so on. So the idea is that, and when I was studying the population health and the health promotion, they used to talk about, even going and studying their living situation, their neighborhood, their, even genetic disposition to the disease, the lifestyle, not only of the patient, but the whole family, and then the involvement of social workers and, healthcare, society, healthcare areas and agencies in the care of those patients and in the management of those populations. So it really goes way beyond what we know and what we practice in hospitals. Sorry. And then, so this is what we were talking about, is that the clinical system must identify and mitigate the effects of social determinants of health and engage the patients and family in their own health management and disease and injury prevention. Can anyone tell me what are the examples of social determinants of health? If you look at the book, actually, they spent quite a certain long paragraph actually talking about the social determinants of health. So anyone can help me with those? What could be the social determinants of health? The economic situations and the living situations, definitely. What else? I will give a hint to Sabita, Najla, and Jimol. There is something that we assess during the patient education. When we were doing the education needs assessment. Socioeconomics, learning ability, the patient educational level, the health literacy. Okay, and I talked just now about the even going into the neighborhood where the patient lives, the physical environment around them, and work-related environment as well. So all of those comes under the social determinants of health. Okay. And then they say that data analytics are necessary to quantify demographic information for population and understand opportunities for improvements. So The population health is only able, as we said, if you are able to link them in groups. So the data analytics will depend on all of those data that's being collected. So you might be able to do a study on, the effects of, for example, illiteracy on the health, on the care of pregnant women having so and so, for example. So you could put them under certain population, and that number is infinite because the kind of combinations you can make between the social determinants of health and the different population you have is endless. It always depends on what you are trying to improve and what opportunities are you planning to come up with. And then they talk about the value-based payment models that the insurance companies and the payers have started enforcing rather than the previously volume-based payment models have made it important for organizations to participate on population health activities. So here these are models that reward high quality outcomes rather than provide fee for services. So before, if you go to the doctor and you do a procedure, the physician takes payment for that procedure you've did. There is more emphasis now on the value-based payment, where if the procedure was done, but I ended up with a hospital-acquired infection, then maybe not. Maybe I would even penalize you actually for causing complications to patients rather than treating them safely and so on. So this is value-based payment, and and then they talked about there are certain domains for healthcare transformations in order to improve population health. So these includes transforming business models. Okay, and here it says facility and services as infrastructure for a system. Can anyone think of an example of a business model improvement to improve population health? What could you think of? Business models improvement. Nursing home for geriatrics could be. So the idea is that you're making facilities and services to become the basic or the infrastructure for creating a full or a bigger system for that. So think of an organization, for example, that has the whole continuum of patient care in one setting, for example. So they would have primary health services, family medicine, along with secondary health services, followed by tertiary health services as needed, followed by rehabilitation and care, after discharge care services, followed by home care and so on. So creating that kind of a structure or a continuum of care is actually one of the business models transformations that you could, in order to improve population health. And then they talk about the clinical integrations, and here they're talking not about the infrastructure of having a system, but integrating the care that the clinicians provide to patients across the continuum of care. And this sometimes are based on an agreement between different providers. They are not in the same systems, but they have agreements or they have certain models of care to continue to provide the services for those patients. The transformation of technology. So here is talking about the electronic health record and the system of hardware and analytics that supports care delivery. So having those data available to you and being able to identify those population health issues in order to improve them. And then payment models, as we say, payment models that actually reward good outcomes or penalize poor outcomes. Now, for example, we know that in Abu Dhabi, that Daman started initially to talk about value-based payment, but then that wasn't implemented yet because, as we say, it's all links to this chapter. Still, the systems do not talk to each other. There's a lot of manual interference for creating claims or writing down certain descriptions. Whatever the clinician writes in the patient care episode is totally different than what goes to the insurance for reimbursement purposes, and that still depends on some paper-based or human intervention that would go into the record, extract certain data, and they might not extract the full data. And we're still getting questions about inappropriate care or complications or stuff that happened through Daman actually to our hospital. Now they started with KPIs. So you could see Daman has certain KPIs, and they tell us until now there is no penalty yet for how you are doing. But eventually that would become part of how the hospitals are getting the payment going forward, because for a couple of years they've been providing you with data on your performance. If you did not improve, that's your call, but do not expect to continue to receive the same reimbursement as before. And then it says data to identify opportunities for improvement and assess the impact of interventions is required also as we transform the way we care for those populations. Still under the same population health issue, they're talking that improvement in quality and reducing costs through population health requires a measurement system that's capable on rapidly collecting data, managing the storage of the data, as well as managing the transformation of the data analytics. So all of these elements is required in order to be part of population health. And here, they gave data or the example of there are certain prediction models to understand and subsequently intervene in population health issues, such as readmission rates for children with diabetes through dietary counseling or home visit. So you see, this actually sounds like a research title that could be done using the availability of data and data analytics in healthcare. Okay. And here was one of the case studies that they actually presented in the book, where the authors of this chapter talked about a quality improvement model for the sepsis that was done back in 2010 in their hospital. And because they've studied all of the patients that had sepsis previously, and I believe they've only focused on pediatrics, what were their systems, what were their presenting characteristics, what were the risks that they had, and they created a system or an alert that say that whenever, and this is at the triage level, so whenever the baby or the child comes to the hospital and he is assessed based on the documented assessment, this message used to come telling them that because of these risks, so the history including tactile in the past 4 hours, underlying high risk condition, and skin characteristics and capillary refill, all of these makes it makes the patient susceptible to become, to have the septic shock. So remember when we talked about the prescriptive level of data, which is the highest level of data, this is what it means. Now it's telling you things that you wouldn't know if you've only looked at the data without considering all of those. And then the clinician can either accept the protocol or reassess the patient. They even provide you certain details of what would you do and how often should you, or how long after the initial assessment you need to assess the patient, and so on. So this is the way that you could use data analytics to actually support the population health. The next elements or the next part of this chapter talks about delivering data for the local quality improvement activities. So this is what we do in hospitals where we have quality improvement practices. And then we talk about, how lacking of access to high quality data is a challenge to the quality improvement activities in the hospital. And then they define high quality data as data that is reliable, valid, reliable, and timely. And then we actually then define each one of them. So complete data means that the source system must capture the data requested. So valid data means that the source of truth can be identified for the various data types and the analyst's knowledge. So it's two things when we talk about validity. It's the source and the truth of the information being provided, plus the knowledge of the person collecting the data or analyzing the data of the valid data fields and tables that they need to look at. Sorry. Sorry. And then it talks about timely data. So intuitive and nimble process for requesters. So here it's the availability of the data, but they're also talking even more than that, where you have a process for a person to request data, and then a clear expectation for those who completing the request and responding to them. So they both know when should I request for the data for it to be available for me for the use of the quality improvement practices. Next, we're talking about measuring the healthcare value. And here we've already touched on it, value-based payment, lower cost for better outcome. So the definition of value in healthcare is quality over cost. This is the simple definition of the value. So if you improve quality, you're improving value for the patients. And if you reduce cost, you're also increasing value for the patient. And the quality is defined by the outcomes that the patient is achieving, plus their experience. And the cost is both the direct and the indirect costs. So the cost of quality, the cost of poor quality, the indirect cost from spending time in the hospital, the direct cost because of the consumables we've used for them. So once you calculate all of that, you'll be able to say what value you are actually offering to those patients. Okay. So quality improvement strategy mostly measure improved clinical processes and outcomes at the provider level. And that was historically, that's what it was focusing on. But most recently, the measurement of the financial impact of the improvement activity became actually a necessary activity for them to be added. If you have noticed, even accreditation bodies like JCI started asking that we present financial impact of improvement rather than only presenting the improvement that we we had, because remember the concept of value is quality over cost. And then they also talked about the challenges with the legal aspect of sharing data between payers and providers. So even the sharing of data between, for example, the hospitals and the insurance company is even a challenge. And they say that these kind of things can be overcome with one-time data use agreement or more comprehensive legal agreements that allows the providers and the payers to actually access more details and data as they go. So now here we're talking about participation in the quality improvement activities beyond the legal institutions. Just give me a minute. Hamza. Hamza. Okay. So now we are outside the scope of the organization or the hospital, and we are talking about levels beyond that. This is talking about, for example, participation in multi-center patient registries or research or quality collaboratives. It addresses that regulatory requirements must be met prior to the participation. Why do you think that's required? If I'm participating in a quality activity that's across multiple institutions, why would I need a quality? But why do I need quality requirements? That would definitely be the reason, or to improve population health. Remember, we said population health is even things that are beyond uh, the boundaries of a country. It could be we're looking at the populations of all diabetic patients, for example, who meet certain standards. So yes, the reason why I will participate is to improve the health for those kind of populations or teams. But the question here is, why would I need to have regulatory requirements or have the approvals of certain boards? support medical legally? Definitely. So still, as we said, the challenge with data security and privacy is even more applicable here, because you're not only sharing it with people within your organization or within the same, payers and people who have relation with the patients, you are even sharing it with external sites. So usually when I see the IRB, that's the institutional review boards that usually review such requests and provide the necessary approvals before people participate in such studies. I remember at once a team from our hospital were participating in a multi-center diabetes study for pediatric diabetes that carried on for a couple of years. And it was like any other research project. It went to the review board. It was approved. It went to the review board, even at the DOH level, because it was even going outside the country, and went through all the approval levels for that. And then it says data collection is usually a challenge when you are part of a multi-center or quality collaborative. And the reason why is that the data collection sometimes is either manual, so you need to collect data manually and then upload it or send it to another, to that data entry team separately. And then it says there's challenges with the access to the raw data. So even though I'm collecting the data from my organization and I'm sending it to you, there isn't available already access for everyone to actually, to review their data. So imagine it's your data, but you have no view on it. It also says limited control by participants over the metrics that are established by the multi-center group for reporting. So you are reporting and you're collecting data, but sometimes you are not even part of the team who are making decisions over what metrics are you going to report and what would you like to see for this type of population. And they say here that sometimes those groups need to be part of committees. And if you are not a member in that committee, you don't really have a say of what data or what metrics will be collected for that specific study. And then here they say because of the availability of the electronic healthcare records and the requirements of more detailed data, the number of data fields being requested is increasing, which is troublesome to the person who is collecting the data. As we say, they're either doing it manually or extracting the reports from somewhere, and then they have to realign the fields to fit into another registry and then enter it manually one by one. And the demand for transparency of quality and outcomes is also increasing. So the idea or the author actually shared an example of how they worked on that and how now they use some certain process to automatically, sorry, this should have been electronic healthcare record, to automatically collect the data from the electronic healthcare record and then push it to the registries to eliminate some of those challenges that were happening initially with the data collections and the data uploading, and then also to be able to meet the demand of increasing data fields and data requests. Then they started talking about the concept of the accuracy and the precision of data. And this diagram actually shows us what they mean by the accuracy and the precision of data. Accuracy is how close the data reflects the true value of what is being measured. So you can see here, this is accurate data. They are around the, let's say the middle point here is the data required, and they are closely around it. So this is make it high accuracy. Precision reflects the exactness of the measurement. So whether the measure is exact, and this says it's high accuracy, but it's low precision. This is saying it's low accuracy, so it's way far than the center point, but it's high precision. It's repeatedly going around the same area. And then they say that this example is high precision, high accuracy. So both is, the data reflects the true data numbers, and it also reflects exact measurement. Sorry. So this is the difference between accuracy and precision. And they say initially in the beginning of the quality improvement, if you're doing a pilot or you're doing, collecting data for just a small BDSA that you want to achieve quick improvements, that you would focus on accuracy rather than precision. But definitely for long-term data and for reporting on management and practices, you would need to be high accuracy and high precision. This is another graph on precision and accuracy. So it provides more definitions of what's considered precision and what's considered accuracy. So the precision is the degree of closeness of the measurement with each other. Precision is often referred as repeatability and reproducibility error. So are you able to repeat and reproduce the same data? Precision is getting consistent results of repeated measurements. So the same measure is giving you the same results all the time. Accuracy is a degree of closeness of the measurement with the degree of the reference value. It's often referred to as bias error and is measuring near the target or true or reference value. What do you think this example? Is it high precision, high accuracy? What do you think? Anyone else thinks differently? Yeah. So this is similar to what we did here, where we said it is low accuracy and high precision. It's always repeating the same, you're getting the same result, and it's all close to each other, but it's way away from the center where it's required. Okay. And again, they say there is statistical ways in which you can measure the accuracy and the precision and calculate that for quality purposes, for literature reviews and so on. Okay. And then we go through the future trends for quality. It says that quality improvement does not only requires attention for data collection and processing, it also requires translating data into information that can drive better healthcare outcomes. There's a need to incorporate clinical, operational, and financial perspectives always whenever you're collecting data. There are more sophisticated technologies for predictive analysis and risk stratification that will be pushed and used in the healthcare delivery and healthcare improvement to drive care through clinical decision support. And then there is also the idea of using machine learning and artificial intelligence. It's actually already happening in order to support data analytics and care. We had a volunteer in our department that used the concept of, in her master's degree thesis, the concept of machine learning in identifying the highest area required for improving patient satisfaction. So it's a certain, you input certain data, the patient satisfaction data, into a certain machine learning tool, and it gives you analysis of which of those elements are connected to each other and what are the top 3 factors that if you have improved would result in a certain percentage of improvement if your care services. So it's really important, especially when you need to prioritize the care and the services that you want to provide for the team. This is the last slide for today. I don't know why, but for me, doing this was actually a bit